to have been February 16th, but now on the 23rd, 2021, held by Teams, Microsoft Teams. So we've just taken roll. Is there any comment on the prior meeting notes? Hearing a overwhelming silence, I will assume there are none and move to legislative update with Ali and Glenn.
Ali, do you want to give a update on the Ways and Means, and I can go over the bills?
Yeah, basically go over, just talked a little bit about Ways and Means with the PEB board, and we'll kind of repeat what I said here. And let's see, is about 3 weeks ago, 2.5 weeks ago, Jeff and Kimberly and I made our Ways and Means presentation to the House Healthcare Subcommittee, and we only really had one follow-up inquiry, and that was with Rep. Nose, who wanted to learn more about the 3.4% challenges, and which I actually met with Rep. Nose last week and talked through a little bit about this strange year with really low utilization and costs, and the fact that we had a fairly significantly lower renewal than 3.4% for both boards last year, and how that makes it more challenging for the following year with the test and the new baseline that's set. So anyway, other than that, it went really well, and I guess we're on our way, and we'll find out if we have to go back and testify any more.
So I just wanted to, I'll try and keep this as brief as possible. As you know, the legislature is in session. I wanted to focus on several of what we call our priority one bills. These are bills that are really directly impacting PEB and OEB. We do also analysis on and follow about 30 others, but that's because those would be bills that, hey, they're adding a new benefit or they're changing costs in some way in the market. The first one I wanted to this would actually be for both PEB and OEB. It's Senate Bill 12. It was introduced by Senator Beyer, and it basically requires that PEB and OEB offer a program, what I call pharmacy tourism program, that would allow, or I shouldn't say allow, that would have PEB and OEB pay the cost for people to travel to Tijuana or Vancouver to specific pharmacies, and then actually purchase their drugs there, and then we would pay for the travel, the cost, lodging if necessary, and then of course the cost of the drug. This is based on a program out of actually the state of Utah, where they select about 12 different specialty medications and allow people to they coordinate the travel. They then also pay. They have contracts with different facilitators, and we did an analysis on this, and there's really a number of challenges with this bill. One is, if you use, the amount of people who have actually utilized the Utah program and their savings, and compared it against what it would be for PEB or OEB, we'd only save $500,000 a year on usually around a $60 million drug budget, and that's actually primarily for specialty medications. There's a number of legal problems with this bill. One, it stretches the concept of the FDA's personal use, so it may not even be legal. Second, we wouldn't be able to get the tax benefit on a lot of these different, both either the cost of the drug as well as the travel and the lodging. And then it also has a number of safety and liability problems to it. People who go overseas, they don't have access to a lot of that safety monitoring and adverse reaction databases and software that they get in the United States. So you could have issues with that, and then Kevin would probably be liable for a lot of that. So we've asked that through our bill analysis that this be reconsidered. The bill hasn't moved anywhere, but you know, we have put our analysis and that there are a lot of challenges with this bill. I wanted to also talk about House Bill 2810, and please interrupt me if you have questions about these bills too. This would require that PEB and OEB offer at least what's called an integrated health benefit. This actually, I would say, is more like a CCO. It would have a global budget. It would use value-based payments with joint risk sharing. And we would have to, each of our carriers would have to offer at least one by 2023 and all of them by 2026. It really is the representative behind this, Representative Dexter, is a former Kaiser surgeon. So it's really trying to adopt total Kaiser-like plans or CCO-like plans across the, you know, PEB and OEB market. Ali's gone through a number of meetings that the representative has had, and they seem to be moving toward where they want to do this on a regional pilot basis, but we have not seen, the bill's never had a hearing yet, and we haven't seen any specific amendments to this bill. The next one, 3044, and actually another one with it is 3074, would require that PEB and OEB only contract with carriers that sign the value-based payment compact with OHA. On one form, 3044 actually says you have to achieve 70% of your payments have to be value-based payments by 2024. A second version, 3070 or 3094, excuse me, would say that you just have to take steps to meet the targets. These bills have, we've identified a number of challenges again with these. One would be it would limit the board's authority over contracts because it literally, that would be a prerequisite for contracting. Second, if say one of our large carriers decided they wanted to pull out because of these requirements, then, and we didn't have other existing carriers or options to fulfill that gap, we would have to go out for an RFP, which would take anywhere from 18 to 36 months and could lead to a lot of disruption within our plans. So in the end, the cost is indeterminate, but it does have a lot of potential, and we put that into the bill analysis, that these bill analysis go to HPA and then also to the government relations team here. Lastly, we just did get some more bills yesterday. One of those is a bill that creates a public option on the marketplace, and it also tries to use PEB and OEB, specifically the carriers, as well as providers who contract with our plans, or actually in this case with PEB, that they have to participate, either offer from a plan standpoint the public option or participate in the public option. So again, that holds a number of issues in regards to the scenario with our plans or if a number of providers pull out.
Okay, any questions of Glenn?
I have a peripheral question that you may or may not know the answer to.
Mm-hmm.
So in a meeting with my commissioners, I guess it was a couple of weeks ago, one of the commissioners mentioned that he was under the impression that there was federal legislation that would change employer benefits to be taxable, to where the employee would, the amount the employer pays for the employee on insurance would become taxable. And I couldn't find anywhere that anything says that, but I thought I would bring it up in this meeting to see if anyone was aware of that.
I not heard that.
Yeah, I haven't either, JJ. That would be a big one.
I was
That would
under
be
the
a
impression he just misunderstood some of the provisions in the ACA, but I wasn't going to call my boss out in a public meeting, so I would look into it.
We can follow up.
Yeah,
we can follow up
Yeah.
though.
Yeah, I looked and couldn't find it anywhere, so I thought, well, I know people that know more than I do. See if they've heard it.
that's all Lee said. That would be a pretty big one that there would be a lot of uproar over that one. So.
I would say
All right,
so.
thanks.
Okay. Let's see, any other hands? Margaret, please help me look for hands up on the bottom there. Okay.
Yeah, I don't see any at this point.
Great, thank you. So move on to part 2 of the Center of Excellence RFI report.
Oh, and Willis Towers Watson is going to be presenting this. Just a quick check-in. Rose, do you want me to share this from my screen, or do you want to keep it up, or I don't know if anyone from the Willis Towers Watson team has it up and wants to control the slide deck. We can take any approach.
I think if you were just sharing it,
Margaret,
that would be best.
Okay. I'm happy to share it from my screen, Rose, if that's easier for you.
So
All right.
a better look. Okay.
Okay.
Got it.
I know. I'm sure.
right.
Thanks.
Okay, you're welcome. And then, so Jenny, this is Margaret. I have it in my control, so just feel free to direct me as you'd like me to move through.
Will do. Okay. So we're going to continue our discussion on Centers of Excellence strategy. I do have Dr. Dickey on the, screen with us today, and he's been working with us in the Innovation Work Group, for quite a while now on this Centers of Excellence program. Lewis out in Dallas, so has also been kind of dealing with power failure issues. So everybody's in good company here, but I'm glad we're all back together. So, all right, let's go ahead and move to the next slide. So just to kind of bring most of the group up to speed, before the pandemic hit, the Innovation Work Group started with looking at the OEB and PEB's top cost drivers. And out of that body of work, it was identified that, musculoskeletal issues were one of the larger top cost drivers. And so we talked a little bit for a few meetings about what are the different ways that an employer can impact that. And so then we took a closer look at Centers of Excellence, and over the holidays, we conducted a request for information, an RFI, with vendors who specialize in creating and administering Centers of Excellence. So out of that work, I think the discussion was there was interest in knowing a little bit more about just a reminder of the problem that we're trying to solve and some of the metrics and opportunity for savings that a Centers of Excellence could have for OEB. And so we'll go through all of the things on this page here in just a little bit of detail. Current spend, the variation in cost and quality, the opportunity to triage to conservative care, and then a little bit about the complication rate that was discussed. And then we'll put all of that together and talk about what the return on investment or the savings opportunity is for OEB and PEB. And then should the group decide to continue working on that, we've laid out some next steps in an approach where the carriers would do a lot of the heavy lifting with some oversight from the innovation work group. And then we'll have a nice discussion about that. Okay. So let's start at the top left. This is just a current state, or some of this is restatement from the original study that was done, which, as a reminder, looked at the spend for the musculoskeletal procedures, hip and knee surgeries, back and spine procedures back in the 2018-2019 plan year timeframe. And what we reported back then was that about 4% of OEB and PEB spend is on these procedures each year, and it accounts for 1,300 procedures each year. And that's definitely going in the upward direction, which we'll talk about in a little bit. Moving over to the right, one of the reasons that several employer sponsors look at a center of excellence is to address variation in cost for these procedures. Now, some employers, right, who have their employees spread across various locations across the U.S. have a very, very big difference in cost. And OEB does as well, as what we found when we did this original study, perhaps not quite to the extent that you would see if you looked at this nationally. However, so, neck fusion surgery varied between $33,000 and $70,000. And then you can kind of see some of the other examples, the hip and knee, or the knee replacement varying between $33,000 and $78,000 for a procedure. Tom Siltebo asked last month about, were we comparing apples to apples here? And yes, we've done in this study that we did originally, we did control for, we took out those procedures that were overly complicated, that definitely increased the cost and complexity, and just really tried to look at sort of a basic average knee replacement or a typical spinal fusion. Some of the variation in cost does occur because if a procedure is done in the inpatient hospital, it's typically more expensive than when it's done on an outpatient basis. Some of that is necessary, and some of that is a little bit up to the discretion of the provider who's ordering the procedure. The original study was done before the hospital reimbursement cap, so that's definitely going to impact or kind of narrow the variation in cost, once the hospital reimbursement cap is fully implemented and we can measure those results. But there's still going to be some variation because not all hospitals are subject to the cap, and then some folks are getting them done outside of Oregon where the cap is in place. Okay, we move down to the variation in quality. This is another snapshot that we looked at when we did the original study. There does exist some quality data on inpatient hospitals by procedure, and we pulled this quality data from a particular database called Quantros, and some of the centers of excellence vendors actually use that database as well to establish their criteria. So in that database looks at 3 years worth of performance by individual physicians and overall at a facility for each of these procedures that we're talking about here. And when we took a look at that, it turns out that most of the procedures are done at facilities that overall scored at the higher than the 70th percentile. But that also means that around 30% of the surgeries were done at a facility that had a lower than optimal quality score for that procedure. But one of the things that's important to do when you're looking at quality is also to look at the individual surgeon's quality score. So that's something that we'll take a look at briefly in the following slides. So if we move down to just a component of variation in quality is that complications rate. And so we did take a look at the complications. We'll talk about that, but essentially we're looking for, if a person had a procedure and then there was a complication that could have been avoided, or if they were readmitted to the hospital shortly after the procedure to address something that went wrong with the procedure. And that's what the complication rate is. So we'll take a look at that. Turns out that OEB and PEBS complication rates are pretty similar to what we see for average plan sponsors who don't have a center of excellence in place. So moving up to the square that's called opportunity to triage care. This is probably one of the more important tiles to look at, because what the literature suggests is that up to 30% of back and spine procedures or hip and knee procedures are kind of preference sensitive and may or may not, meet medical criteria in terms of the best outcomes. And there's been some studies who have followed folks, particularly in spine procedures. And it turns out that, when they followed them over a period of about 12 months, when they had physical therapy or conservative methods, a lot of the time the outcomes were very similar to someone who was similarly situated and had a surgical intervention for that spine procedure. So just something to be aware of. And this is also something that the Center of Excellence vendors typically will include in their savings analysis, or they should, the better one. Okay, and that brings us down to, if we put all of these things together and if we can quantify them, which we'll do for you in this in a couple of slides, then that outlines what the savings opportunity is for OEB and PEB in putting these all together. Okay, so that's our overview. We'll give you a little bit more detail on some of these on the next few slides. Let's go to the next one. Okay, well, this slide, we just went ahead and pulled for you where the members are who are receiving these procedures. I think there was some question about, having, addressing the needs of those who are in rural communities in addition to those who are along the I-5 corridor. This shows you where, so this is like a heat map of where the members are who got one of the procedures that we're talking about. And they are kind of concentrated along the same lines as to where the overall population is concentrated. So pretty heavy in Marion County and along the I-5 corridor. I think as a second step, we can certainly take a look at where the procedures occurred, and it's a bit more of an intensive exercise to extract that just based on how the data comes over on the viewer. Okay, let's go ahead and go to the next slide. Okay, so this is a little bit more detail on that complication rate that I mentioned about the hip and knee and back procedures. So to find the complication rate, we did pull a little bit more recent data. So we looked at both OEB and PEB procedures done between July 2019 and June 2020. It turns out that when we looked at flags for complications and hospital admissions that were within 30 days of the original procedure, it turns out that about 80 members during this time experienced a complication or a readmission. And the range that we turned that into is about 3 to 5% complication rate, which again is pretty similar to what we'll see in an average employer sponsor population. So the best in class is at 1%, so that's lower, and those are the kinds of things that a center of excellence program will look to guarantee either overall as a complication rate or specifically for the procedures in the form of warranties. Any questions about, I think, Louis, you had a little bit, you took a little bit of a deeper dive into these. I don't know if you have anything else to add here.
No, I mean, one of the reasons that it's a range is that we pulled every admission within 30 days of a procedure, and then we looked at the diagnosis for that readmission. Some of them were pretty obvious related to a complication, some of whom it wasn't as clear but could have been. So again, that's why there's a range depending on how many of the could have beens were actual complications versus just something else that was coded and was incidental and not related to the procedure.
Okay. Any questions from the group? Okay. All right, let's go ahead and go to the next slide. So as I was mentioning a minute ago, we did take a look at some of the quality scores for the hospitals that performed the hip and knee replacements and back and spine procedures for OEB and PEB members. And so the pie charts, the colors, sometimes colors can be hard for folks, but the colors align with the quality score. So the green and blue pie slices are the highest levels of the quality score, taking everything all together, all the physicians and surgeons within a facility. And then the yellow is the medium quality score, and then the red is at the lowest quartile or percentile. So this is kind of what we talked about earlier, in that, about 30% of members did get a procedure done at one of those hospitals with a less than optimal score. Doesn't mean that their procedure, those are the ones that had the complication. It just means that when we're looking at data over a specific period of time, it kind of tells you what may likely happen more frequently than the ones in the green and blue. We did also look at, we took a look at the purpose of the pie chart on the right-hand side is to show you that, even a hospital that has a great overall aggregate score, like Salem Hospital, individual surgeons at that hospital have different quality scores. So when you're doing a center of excellence strategy, it's really important to look at both the hospital or the outpatient facility and also the surgeon, and make sure you're kind of getting the best of both. Louis, do you have anything else on here?
No, I'm fine.
Okay. We'll talk a little bit about, in the next steps about what quality databases to use, but I guess just point out right now that, Quantros is one data source, and it is a relatively large data source, but individual carriers like MODA and Providence will have their own quality metrics that they track in, within their own plan, which is also good to add to the mix here. Okay, so let's go ahead and go to the next slide. So the next slide just gives you a snapshot of, if you want to look at individual surgeon scores, that is available in this Quantros database, and also should be available. The carriers, if they're tracking it, should also be able to report on this as well. It may take a little bit of time, but this is the kind of information that comes out to drive that quality score, and that's mortality rates, complications, readmissions, and patient safety. So they take a look at 3 years of data and come up with a score. So this is just an example of the kind of info that can be had. Okay, let's go ahead and go to the next slide. Okay, so here's where we calculated a return on investment specific to OEB and PEB combined if a COE program were to be implemented. So the savings varies or ranges between just under 5 million to just under 10 million for, again, OEB and PEB combined. And some of what determines that is the percentage of members who participate in this program. It depends on how OEB and PEB set this up. If it's a mandatory requirement, you may have, obviously larger than 50% participation. But if it's purely voluntary and you're just letting folks know about it, you're probably going to have less than 30% participation. So setting the right incentive is going to be important to drive participation. And that incentive may vary. It might be appropriate to vary differently between OEB and PEB programs. So as I mentioned, here's the savings range. Usually the vendors, when you contract with a COE vendor, will guarantee at least an ROI of 1-to-1, meaning, there are fees typically associated with administering the program, and so they would guarantee savings of at least equal to those fees. Though obviously a higher ratio is much better.
Jenny.
Yes.
So as we're developing more and more programs, and like we have the CCM models in both PEB and OEB, as we may see some improvements, if we were to have hired a COE vendor, how do we determine who gets credit for that?
Yeah, that's a great, that's an excellent point.
Does Dr. Dickey have any insight on that?
Well, if you're hiring a third-party vendor where it's not through the health plan, then you're going to know what the cost of the program is, as well as the savings and the avoided cost. If it's run through the health plan, then again, you could look at the difference in cost of what it would have been versus what it was contracted at and capture some avoided savings. But there could be, to the extent that your value-based payment covers the orthopedic surgeons, or to the extent that you have any bundled payments that are already there, then you would need to sort out those two.
Yeah, and it also depends on, I admittedly more familiar with the OEB programs than the PEB programs, but there are risk sharing arrangements on the OEB side. So, even a center of excellence would be helpful to providers who are under a risk sharing arrangement if it in fact lowers the costs of that program.
The other part of that too would be that under a value-based contract, if you had that in place and you had the center of excellence, which is inside the health plan, there could very well be surgeons or physicians that are under the value-based program, but they're not participants in the center of excellence because for whatever reason they didn't make the quality cut. So it would most likely be a subset.
Yeah, go ahead. Yeah, more questions? Okay. Yeah, so, based on the feedback from the last meeting where we went through the responses to the request for information, the direction at the end of that, other than wanting to understand a little bit more about the savings opportunity and the complication rate, was that, it may take a significant amount of time and procurement activity to go through a formal RFP for a center of excellence vendor, but that it might make sense instead to work with the carriers who also proposed that they could work on this and set this up for OEB and PEB, to run that. And so in the next section, we outlined what the potential steps and timeline would be if the group decided, yes, we want to move forward with this, and yes, we really want to work with the carriers to make this happen. So I just want to make sure that see if there are any other questions before we move to those next steps.
Well, so this is Sean, and so I know you mentioned this, but I guess I just kind of wanted to probe a little bit more around this point. In discussing it with the plans, do we get a sense from them that they actually think this is plausible, that there would actually be cost savings, from their point of view? Do you have a sense of that?
Well, in the RFI that we did ask the carriers, what their capabilities or approach would be, and they both. And I'm really kind of focusing on Providence and MODA here, really, because those are the two that make the most sense. But yeah, they both indicated that they would like to pursue a center of excellence strategy, flavored in their own way, right? So OWEB, has a different network strategy perhaps than Providence, right? So I think they're both aligning their strategies towards their own network, the unique aspects of their network and the risk sharing arrangements and that kind of thing. So yes, they both proposed that they could do it. It would take a bit of time to put it together. And so, yeah.
So the reason why I asked that so directly is that, presumably they would get something out of it potentially, which is higher administrative fees because they're administering it. And so, kind of back to the who gets credit for what sort of thing. Yeah, I'm just discussing it out loud, that some of the savings could be, it will be, it says it here on the slide, assumption that administrative fees will take some of the savings, right? And so I think it's like real careful about like, yeah, how much is appropriate, and that's tricky because only they really know the details and guts of the whole thing, and it's difficult from us on the outside to. So I've just seen this kind of happen before, where it's like you do something to save money, but in the end, when you actually balance out the costs of everything around saving money, it kind of doesn't. And so that's why I'm just bringing it up. Like, how do we know? Like, how? Yeah.
Well, yeah. To be fair, the RFI exercise was really a request for information. And so, the carrier's responses to the fees section in there was more of like a TBD. And I would expect that the fees, just as a consultant, I would expect the fees to be lower for a carrier solution than for an outside vendor for a variety of reasons. And so that's certainly, I think that's an excellent question to ask. And I don't think we know what those fees are until we get a little bit deeper into, some of it's going to depend, like how many facilities are we talking about? What's the benefit design that's going to need to be administered? How frequently is the reporting that's going to need to be happening? What does the bundle look like? What is the warranty? All of those different things are going to impact flex deal it. I think one question to ask is, why are the carriers not doing this today? And the
right.
answer, yeah, well, but that's a fair question. But the answer probably is that, carriers have traditionally set up their programs to be workable for everyone, right?
Yeah.
To give everyone choice and access and something close by. And over the past several years, there's been a lot of concerted effort to work on narrowing network and identifying who are the higher performing providers, and maybe we should steer people to that. So, I don't fault them for not having this already baked. But, yeah.
It's a good point. And to be frank with you, there have been, in the years past, the PEB board in particular has pushed on the plans to expand their networks, right? There was a lot of emphasis on network adequacy, etc., and access. And I do understand that, and just want to acknowledge that certainly has been a pressure from us. But here we're talking about a specific procedure or set of procedures that have a very high variability of quality and costs. And we're talking about compensating our members for the inconvenience, for the purposes of. But anyway, yeah, feels like the connection to our next topic around performance guarantees sure does feel like an important, as you've said, as an important component of designing this is like
Yeah.
some sort of, we're expecting these savings in order to get these fees, So,
Well, that's exactly right. And so it's important to determine how you're going to measure the success and the guarantee before you actually launch the program, and not say, let's launch it and then figure out how to measure that afterwards, which sometimes does happen. So we're at least usually very specific about needing to establish the parameters ahead of time, which takes some time, and especially to get everybody on the same page. Before we leave this page, though, I think that I didn't really mention the impact to reducing the variation in cost. So what we've modeled here in this ROI savings, just so you know, is that a lot of the vendors, not the carriers, but the vendors said that they could develop a bundle for these procedures that's somewhere between 100 to 150% of Medicare. So definitely lower than what's happening today, even probably if we look at the 200% cap. That said, not every employer has a 200% of Medicare cap for all their services. So one of the challenges is going to be get to figure out with the providers who's going to accept reimbursement at 150%, and they will, if they're promised some volume in return or some opportunity to save money based on avoided procedures and that kind of thing through the bundle. So we can talk a little bit about that, but I felt like, I didn't really bring that up, but that definitely went into our ROI savings. We kind of assumed on the higher side, the bundle at 150%, just with that knowledge behind us.
Before we get too far away, Sean, I appreciate you raising that particular issue. And I think that it's incumbent on our consultants to validate a reasonable cost for adding these services. But you also implied something that I think is substantiates why it might be better to pursue this within our own carriers, and that really is paying attention to social equity, because access to care, especially if it's more dispersed and people have to get outside their area, makes it more challenging. So the balance between that access that we push for in developing our CCM models and the savings and the quality is really quite a balancing act. So,
Good point.
and Jenny, I really appreciate your explanation. I thought it was good.
Okay, good. All right. Well, again, assuming that the group, well, you'll have to tell us if you want to move forward with this, but assuming you did want to move forward with it, we wanted to outline for you, the next steps for working with the carriers and like how long that would take. So let's just go ahead and go to the next slide. Okay, so, these are the next steps that would have to happen. The first one, which would probably take a fair amount of time, is figuring out the criteria for selection. So both MODA and Providence had proposed taking a look at specific provider facilities and providers who might be eligible for such a program. And there is criteria that exists today at the BRE Collaborative that can be used to kind of help make sure that that criteria between the two carriers is similar and aligned. But understanding that everybody measures something a little bit differently, and they're going to need to go in and find the data on individual providers and facilities, will take a little bit of time. From there, the idea is to identify a handful of provider or facilities and surgeons who would meet the criteria. And then the next step would be to approach this, follow the carriers to approach those facilities and surgeons and talk a little bit about, do you want to participate in this? Here's the upside is, volume that comes to your facility or to you versus needing to provide some guarantees and warranties and, a fair amount of reporting. And then the third step would be the benefit design. That's the third design, is figuring out what's the incentive design for the Center of Excellence. Is it going to be mandatory or voluntary? Developing a travel and member support benefit. So just to your point, Jeff, about health equity, you can't just sort of give people some money to travel. You really have to actually help them make it easier and support them with some education along the way. So they don't just, I think we talked about this last month, so they don't just show up and go, oh, my surgery's tomorrow. They need a little bit more support than that.
And haven't there been studies where people who are supported by family members or those close to them recover faster? Where there's some presence?
There may be. I don't know, Louis, are you familiar with any studies like that?
Yeah, I don't know if it's a study, but typically if you're going to do a travel and lodging benefit, that would incorporate the travel for a companion so that the member would not be alone, which helps provide, to your point, Jeff, some of that family support while they're there. And also the surgery could be potentially 50, 60 miles away, but part of this would be that if there's any sort of post-op physical therapy, then that could be done in their market. So they're not having to travel for that type of follow-up care, like I said, relative to physical therapy. And
yeah. Well, I think we even have some regional challenges on follow-up care within the state. I don't know that for sure, but I wouldn't be surprised.
Mm-hmm.
But I think this is a great thing for us to be pursuing, just so I'm not misunderstood.
Okay. So Margaret, do you want to go to the next slide? Yeah, I think we've presented this slide before. It's just a little bit more detail on why the first step takes a bit of time to do, is just understanding the data that you have, trying to set the parameters for the volume thresholds, taking a look at accreditations and specific procedure complication rates and that kind of thing. Just takes a fair amount of time. And then we want to go to the next slide. Okay, so yeah, here's just a suggested timing for so this, I think it was step 1 on the prior slide, but here it's phase 4, which is if you were to move forward, you'd move into phase 4. And that's establishing that criteria. We've got here, I think 5-6 months. So for that, and honestly, that could take a little bit longer depending on the work, but certainly could be, I would envision this as a joint exercise with the carriers, innovation work group staff and consultants, just again to understand what each of the carriers can do and would propose, and make sure that at least the way they're going about it or the metrics that they're using would be aligned. And then, yeah, go ahead.
It seems like you're calling for a decision at this point.
Yeah.
So, Kimberly, what are you thinking as chair of PEB?
Well, I think that, all the work that we've been doing, I definitely think that it's paying off. And I guess I need to, we'll bring it forward to the PEB board, right? So
yeah,
it won't just be that I make a decision, but then that the board, we have some sort of presentation for the board to then evaluate or that kind of thing, something to that. I know that we definitely are very much, we are moving this direction as a board, I guess is the way I'd word that.
Sure. Well, not to hang you out to dry, I was going to ask Sean next.
Well, I think you need to, yeah, well, we would need to put something together to say why this makes sense, you know, what the risk is, what the reward is, within the board's long-term strategy, how this really fits and makes sense.
Well, okay, so I'm asking the question, do we need to now take it to our boards and suggest that they approve progressing with this? And are you saying then, Ollie, that we need something more formal in terms of a presentation to go to our respective boards?
Yeah, I mean, I think so. I mean, I think, you know, this would be good information, obviously, to make this more tailored to, you know, the specific board that you're going to present to, but because they are a little bit different as far as where they're going strategically in the next, you know, 3 to 5 years. As far as like medical RFP and that kind of thing. So, but as far as the overall partnership and the benefits of it, you know, I think that that it kind of sells itself, right?
Well, it does, and this exhibit shows phase 4 commencing this next month.
Right.
And so it seems like our boards should be saying yes from this point on.
So yeah, I agree that it feels like what we have come to, and I'm sort of checking in here with everyone, is that we as a work group are basically asking the PEB staff to put together and our consultants put together a more formal presentation for each board. We recommend going this direction as a work group, obviously with a lot of these details having to be ironed out that we just talked about, right? But, you know, I think we're also maybe in a place to make the decision from our own point of view that internal, you know, using our own plans is the way to go as opposed to some sort of external. I think we've kind of made that decision, at least as a work group, or maybe we can. The only part about this that feels like, you know, it's just going to need discussion is preparing the members for this and around that whole like you know, limited access thing. And that requires a communication strategy, you know, which, you know, this is a community, it's a center for excellence. I mean, that's part of it. It's just like, we want you to go to the place that has the best outcomes, and we're willing to pay you to pay for your travel, etc. But, you know, there's going to be some people that don't want to do that, and so we need to be prepared for that. That'll be the discussion, I think. But that all being said, I don't know if we need a vote per se, but basically to proceed with presenting to the boards with our blessing, you know?
Yeah.
I think that's the one thing that's missing there, Sean, is the incentive. You know, what really is going to make members good with this and want to participate and travel somewhere is, and maybe that's what's missing, is the range of incentives out there, rather than just a travel reimbursement. Is there some other incentive that would make this, want people to be positive about it?
Sure.
Yeah,
That comes under benefit design.
We did include the incentive into the calculation of the ROI. So the ROI that we calculate is net of an incentive. Now, that incentive could vary depending on what you,
Sure.
you know, what ultimately decided.
Well, thank you, Ollie, for bringing that up. Great point. And it does feel like whatever the incentive is, man, it's probably worth that the incentive kind of looks similar between OEB and PED, just so that it's not vastly different between the two groups, because then that could cause problems. So maybe that is a specific thing that we come with a recommendation on. I don't know what that does with our timeline, but it's a really great point. And if we want both boards to sort of consider the same, incentive model, it probably would be best to not send the boards off to go discuss it separately without some framing.
Right.
So just a side note, isn't our first concern that our members get quality care?
Yes.
Yes.
So even if this netted out to be marginal savings, it's in the best interest of our members to be pursuing this.
Oh, I think so.
Yeah.
One thing I'd like to put in is when we talk to our members, the number one issue that people say is paramount to them is cost. I think quality is important from the board perspective. We recognize the importance of that. But as someone who's been on plans that have had things like this, I'm in favor of saying thou shalt not, would you please, and if you will, here's some benefits. I think the program doesn't work if it's mostly voluntary, and there is some disruption issues when you put programs like this in. But I think if you come to a member and say, we have been tasked with doing innovative and challenging decisions to reduce costs or more likely to mitigate potential increases, people understand that. And the options are much higher costs or stuff like this.
Yeah.
When I had a dental provider when I worked for the city of Newport, and I had to have a tooth extraction, and I had to drive to Tigard. And that was just part of the gate. Oh, you want your tooth extracted? Cool, you go to Tigard.
Right.
Yeah, but it is a good, I do agree that, quality is super important for members because, if you've ever been faced with having a pretty significant procedure done, you're worried about cost, but you're also like, well, who is this surgeon that I'm going to be going to? Like, what is she, how is she or he, how does she perform the procedures? And am I going to be assured of getting a good outcome? And so while, a program like this, you may be asking members to travel farther than they would feel comfortable if they know that there's been a pretty significant process to ensure that the best providers are being selected. That really does help them feel a little bit better about the extra effort.
Yeah, I think that the catalyst is our communication on the why, and it's a mixture of we want the best outcomes for our members. That's why we're sending them to specialists who do this all the time. And because they do it all the time and they have lower, complication rates, it's going to actually cost less as well.
Yeah, that's a great point, JJ. I think trust is really what's going to make this successful or not.
Yeah. So totally agree, and therefore part of this package of decisions is there's going to be a communication plan to basically describe what JJ just said, right? I mean, it's just like, this is why we're doing this. This is the benefit to you. Here's the, literally the way it translates into the benefit design. But ultimately, this is the best out. We're doing this because of the best outcomes.
Yes. Okay, so we are just going to advise our respective boards that we're moving forward with this as a main concern of the innovation work group.
I think we just need to take the boards for a thumbs up, thumbs down on innovation work group recommends moving forward on this, yes or no. And if the answer is yes, then we move forward with it.
Okay. So Ollie, are you going to take on the mantle of preparing something a little more substantive to accompany discussion?
Yeah, I think so. You know, we can coordinate and put something that's consistent, but unique to each board, as far as the why, the ROI, and the value of it, and whether or not we get their consent to move forward.
Okay. So you got 1 week for the OA board. Okay. All right. Back to you, Jenny. Are you done?
I think that wraps us up.
Okay. Thank you. Really appreciate the effort on this.
Yes, great job.
So we are at short break, I think, and then we go to performance guarantees.
Yes, just checking in. We are scheduled to take about a 10-minute break. So I have that it is 2:36. So should we say back at around 2:46, 2:45, and we'll resume.
Great, thank you.
You guys can watch me sucking on a very unhealthy sucker. It's been one of those days where I feel like I need sugar. It's like,
Hey, this is Michael. Can you hear me?
yes.
Okay.
Hi, Michael. I was just going to email you back. It sounds like you're having some technical difficulties today.
Yeah, I keep getting kicked off. I'm not going to take it as personal rejection here, but one of the things I was going to mention in the one slide that Jenny had about criteria was geographic location, because that's come up with PEB before. And I think the appetite from PEB was that was my recollection, they wanted providers in the state of Oregon as opposed to New York State or Florida. So I think that will be an important thing to add to the criteria and have the respective boards weigh in on that. So that's just, I'm not sure that
Thank you.
If that got through or not.
So
No, I think that's a good point, and that kind of falls under that benefit design category in terms of all of those decisions that need to be made around the structure of the program.
you're saying preference, not exclusivity.
I don't know. I just raised the question, actually. Yeah.
Okay.
And if the preference is Oregon, then how far away is too far away? I mean, is it East Coast? Is it?
It's not Tijuana.
Yeah, Tijuana. Well, there was for a while a lot of foreign travel, for surgeries, but
yeah,
that what do they call it, medical tourism that seems to have died off, not quite so popular anymore, but
we just had a family friend get bariatric surgery in Tijuana just this last summer, which I know I was a little shocked.
Well, actually, you bring up a good point. Then is it the United States? Yeah. I mean, just saying.
I'll resist all further temptation and just call us back to order. Okay. So who's up on the performance guarantees? Who's that?
Performance guarantees. I think I am going to kick things off with a little bit of what I would consider an introduction and kind of a lay of the land in terms of where we currently stand with guarantees and PEB and OEB contracts. I'm going to pull up my slide deck here, and just before I get started, want to just let you know to feel free to chime in with questions as I go. When I have the slides up on my screen and I full screen them to share them and have the kind of view optimized for the meeting, it's kind of challenging for me to toggle back and forth and look at the participant list and see hands raised and stuff like that. So I would just encourage you to just speak up and interrupt me rather than being polite and using the raise hand feature. That is an appreciated feature, but I think given the technical setup, just speaking up is fine. So I'm going to go ahead and get started. Let me get these pulled up. And so kicking this off again, we are going to begin a couple of months of work related to performance measures and performance guarantees in PEB and OEB contracts. And the Mercer team has done quite a bit of work to pull together kind of an initial slide deck that delves into some of the explanation around performance guarantees and considerations for developing a framework. Before they dive into that, which Michael will do right after I finish these slides, I wanted to start off with just giving kind of an overview of where we're at and why now is a good time for this work and sort of what's to come. So just kind of in brief summary, PEB and OEB, this deck, what we'll talk about, as I noted, is the brief summary of our current performance guarantees. And then just kind of the timeline and approach we're proposing for reviewing, refining, and aligning measures and fees at risk for upcoming contract renewals. So PEB and OEB medical and dental contracts have included performance measures, and fees at risk apply to certain of these measures for a number of years. However, over the years, contracts have not been fully aligned. There's been differences across PEB and OEB, as well as differences with different carriers. And over the years, we've moved to much closer alignment, but I think we still have some room to further optimize that. Just a note about kind of how we've pursued this in recent years, the fees at risk have generally been tied mainly to clinical quality measure performance. And those fees at risk were suspended during the 2020 and 2021 measurement years. And that was in recognition of the health system disruption and challenges that were created by the COVID pandemic. So we're currently in a spot where we are working on contract renewals and need to think about reporting and guarantees for the 2022 measurement year. So right now it kind of provides a good opportunity for us to review and refine the performance measures and fees at risk we have. What we have had in place historically, and I know this, think about this in terms of the fees at risk we've had prior to the COVID pandemic, because as I noted, we have suspended these due to the pandemic challenges. But in OEB medical plans, fees at risk historically have applied to both administrative and clinical quality measures. And in terms of the amount, the maximum pool of fees at risk are set at 15% of the administrative fee portion of the rates for the plan year. And again, the administrative fee portion of the rates is in the range of, and someone on Jenny's team can jump in and tell me if I'm wrong here, but it's in the range of about $70 to $75 PEPM. And so 15%, oh, thanks. Thanks, Jenny, for confirming that. So about 15% of that maximum pool of fees at risk is tied to performance on the administrative measures, and 85% is tied to clinical quality measure performance. For the PEB medical plans, things have been done a little differently. Fees at risk apply only to the clinical quality measures. PEB doesn't, at this point, apply fees at risk to performance on administrative measures. And the percentage of fees at risk varies by carrier, and it's calculated or determined in different ways based on fully insured versus self-insured plan arrangements. The goal in the amount has been to try to have approximately comparable amounts at risk relative to the membership enrolled in each plan. So for Kaiser, the amount at risk, and again, these reflect amounts up until fees at risk were suspended for the pandemic. But for Kaiser, it has been 0.5% of premium with a $750,000 cap. For MOTA, it's been 5% of ASO fees with a $400,000 cap. And for Providence, it's been 2.5% of direct admin fees for each statewide and PPO. Plus, Providence has had an additional 18 to 25% of the ASO fee at risk for additional metrics, and that's dependent on whether or not enrollment thresholds are reached. And that has a $1.25 million cap for that contract. So as you can see, there's some variation that exists in our contracting in terms of how measures and the fees at risk have been assigned and applied. On the dental plan side, OEB has 10% of the administrative fee portion of the premium at risk. And the administrative fee portion for dental plans is more around in the range of about $8 to $11 PEPM. So of course, lower administrative fees on the dental plans. For PEB to date, there are no fees at risk for dental plan measures. The next couple of slides just list a brief listing of the types of measures. These are pretty comprehensive, but I will say, on the administrative side, by no means exhaustive. Over the years, there's been a little bit of flux in the measures. But as you can see, for the medical plans for administrative measures, you're talking measures such as claims processing accuracy, claims payment turnaround time, telephone response time, call abandonment rate, those types of measures that really get at the administrative performance of the health plan and how well it is handling claims processing and providing service to members in terms of response to questions and member needs. On the clinical quality measure side, there are a couple of things that help kind of guide us as part of OHA when we look at our clinical quality measures. The first is the statewide aligned measures menu, which is established by the Health Plan Quality Metrics Committee. And that menu of a little over 55 measures on that menu currently is essentially the list we choose from when we identify clinical quality measures that we want to track for our population. Now, the Health Plan Quality Metrics Committee establishes that menu, but along with selecting the measures, additional work that needs to be done is identifying benchmarks and targets that we want to track to. One step is selecting the measures themselves, but then the next steps that follow from there are how do you define good performance? How do you provide excellent, or how do you define excellent performance? What sort of benchmarks and targets are you using to determine whether performance is where you want it? So we can refer to the statewide aligned measures menu as our source for identifying measures we want to use. We also work closely as part of OHA to track what the Metrics and Scoring Committee is doing, which that is the OHA staffed committee that selects measures for CCO quality incentive programs. And the Metrics and Scoring Committee also determines the benchmarks and targets for the measures that are selected for CCOs. So you can see on this slide, we've listed the measures we currently or most recently have been tracking for quality. And when I say most recently, even though we have suspended fees at risk for specific performance targets on these measures, we are still, carriers are still required to report. So we are still receiving performance reports on this data during the pandemic disruption years, even if we aren't tying dollars to achieving specific targets. And then on the dental side, we have a briefer collection of dental measures. These incorporate both the administrative type and service related measures around things like claims processing and telephone response time. And it includes a couple of measures related to specifically to utilization of preventive services, both for adults and children. And then we do currently track a dental sealants measure for children. Dental quality measures are a challenging area just because there is less existing, less out there in terms of validated benchmark measures to select from when trying to measure dental quality. So I think that's an ongoing area that we're going to just, continue to track with what the Health Plan Quality Metrics Committee is doing in that regard, and what other measurement experts out there identify in the realm of dental quality. That all said, in terms of just kind of an overview of what our contracts currently do, we have a rough timeline we're proposing for what we would do over the next couple months in the innovation work group. And so specifically, starting with this month's meeting, we would open up the conversation and have some discussion around performance guarantee strategy and objectives, including the different categories of performance. We've talked about administrative performance and clinical quality really briefly in this presentation. In Mercer's next presentation, they're going to introduce some thoughts around some other categories of performance where we may want to explore guarantees. Then looking forward to next meeting in March, we're proposing that the work group would refine the performance guarantee categories for contracts, review and consider proposed measures within categories and proposed weighting when you assign performance guarantees, you may decide that some categories of performance are more critical than others and therefore are weighted more heavily. Also consider measure benchmarks and targets and the sources for those pieces of information. What do we consider our benchmark sources? And then review and consider level of performance guarantees, that being the dollars at risk specifically. What level of guarantee do we want to strive for in our contracting? For April, we currently have no innovation workgroup meeting planned for the month of April, being that it is kind of the peak of plan renewal seasons. Our current expectation is that with the boards and a lot of work going into finalizing plan designs and renewals for the next benefit year, that we would take a pause from this meeting in April. And then return in May to make final decisions on performance guarantee categories, measures within categories, benchmarks and targets, level of guarantees, and weighting. And this is what we would recommend for OEB and PEB upcoming contracts. For OEB, that would be the 2021-2022 contract, and for PEB, it'd be the 2022 contract. So kind of the specific decisions related to what our contracts are going to include. And then additionally, we would like to establish a process for ongoing governance of performance guarantees across OEB and PEB contracts. And I think through this process, staff and consultants will be able to make some recommendations about what an ongoing governance process would look like. The goal being that we would have an established formal process for annually reviewing what's in our contracts and refining it and making updates as appropriate so that our performance measurement and performance guarantee strategy stays current. Are there any questions about that information? All right, if there are none, I can hand it over to Michael, who can walk us through the next section of this conversation.
Sure. So I'm a little newer to the IWG, so I just want to quickly introduce myself for those that may not be familiar. Michael Garrett, I'm a principal in the Total Health Management Specialty Practice at Mercer. Reside in Seattle and have been working with PEB since, I think, 2.5 years now. I've been working with PEB, mainly on the strategy work. So I'm not an actuary. I'll just let you know all that right off. I have a care management and a behavioral health background and also do a lot of work around benefits. So anyway, the purpose of this presentation, you go to the next slide, is to really define performance guarantees. That's kind of what's the task for today. What are the categories of performance guarantees? I gave a few examples, but as Margaret said, then next month, depending on the feedback from the two boards, we can flush out some more specific examples by performance guarantee category. I did slip in here the clinical quality measure criteria, which is actually from the Health Plan Quality Measurement Committee. That's a mouthful. Just so you know that the clinical quality measures, what that's based on already, because you would adopt those into your PGs, and then any feedback and next steps. On the next slide. So PGs, you can read the slide. I'll just talk. PGs basically are a way of, if you would, kind of having a warranty on the performance of the vendor or the partner, supplier, whatever word you want to use. And what you're trying to focus on is key measures of the scope of work that they are providing to you and to your members, so that you know that they're doing a good job and that you have made a wise decision in purchasing services from that particular vendor. And so that their fees are at risk for performance. So some people, it used to be called pay for performance a while ago, although that terminology is kind of not around as much. And there's two ways of doing this. One is carrots and the other is sticks, if you would. So carrots basically meaning that they get paid more money in achieving certain measures. Sticks meaning there are financial penalties or withholds if they do not perform. With truly administrative services only contracts, typically it's the financial penalty route. Carrots, if you would, or incentives, or when there are value-based care arrangements like a coordinated care model kind of arrangement. But for just garden variety administrative services only work, it's usually financial penalties is what the performance guarantees consist of. I'm sorry, now you can go to the next slide. So here's some suggested goals that I have putting forth to you for your consideration. So first, in no particular order, being good stewards and resources of and fiduciary responsibility, because these are probably the largest contracts you have with your respective boards. To monitor and optimize the member experience. Remember, it's the interaction a lot with the carrier or the administrator, but also can be with the healthcare delivery system. You want to achieve adherence to nationally recognized evidence-based quality standards so that you know that your populations are receiving good quality care, and that your benefit partners or vendors are really administering the best-in-class health plan experience for your membership and for you as an organization. So those are some just suggestions around the goals of what you're trying to accomplish with PGs. And then here's some guiding principles. So clearly defined with benchmarks. So Margaret alluded to this already. So the clinical quality measures are typically based on the Hedis Measures health plan employer data and information set, I think is what it used to be called. Now they just call it Hedis. And these are nationally recognized benchmarks, measures. Benchmarks vary. There's a set of benchmarks for HMO plans, a set of benchmarks for PPO plans, and then there's a blended HMO and PPO. So it's kind of two different kinds of sources there. It is critical for monitoring the financial performance of the plan, because part of what you might want to be monitoring, I think, is the financial accuracy of the claims administration. You want to pick metrics that are nationally recognized whenever possible or commonly selected for like the administrative and operational. You want to select measures that are relevant to your population. So there's a plethora of clinical quality measures, but you want to make sure you select those that are relevant and to all aspects of your population. So adult measures, pediatric measures, physical health, behavioral health. And I saw a mix of that when you were putting them up. Preventive measures, chronic care measures, and so forth. You want the measures to be impactful to your membership. So things like, although maybe not too exciting, things like block call rate and average speeds of answer and claims turnaround time may not be the most exciting measures, but if your members are having difficulties in getting through on the phone, their claims turnaround time isn't fast, that is not a positive experience with the health plan. So that's why I put it there. Also, the clinical quality measures too, of course, would impact member experience. You want to pick measures that are relevant to the performance requirement of the benefit partners. So things like claims administration, the customer service line, and so forth, those are all relevant to the performance requirements that you're contracted with these benefit partners. The next one, balance reporting of actionable outcome-focused measures. So we want really robust measures that are looking at outcomes and administrative burden. You want to look at both of those. So you need to balance that out in terms of, yes, it's a good measure, but what's the administrative burden in getting reports on those measures? And then align with, as possible, with the overall OHA efforts for statewide health system statewide performance. So those are the suggested guiding principles as you have an eye towards PG. So holding the benefit partners accountable for their performance, looking at member experience, what are they nationally recognized measures, clearly defined benchmarks, look at the balance between good, robust measures and as well as the administrative burden. So I'm going through this pretty quickly, but and these are just my recommendations and Mercer's recommendations for you to consider as you think about performance guarantees as a framework for approaching. So principles for benchmarks and goals, use national benchmarks, as also asked of us. Evolve and modify the PGs as it makes sense over time. So when you have lessons learned or there's plan changes or plan design changes, you may have to modify them. Next one may not make as much sense, and it's retire metrics that are no longer valid or when the benchmarks have been consistently achieved. So if you're measuring, I don't know, say colorectal screening, and your plans are consistently meeting or exceeding that benchmark, it may not be worthwhile measuring it any longer. You might want to have them report only on that. But if they're meeting, exceeding it consistently, maybe you need to look at other metrics that that they're not achieving or exceeding to incorporate into your performance guarantees. And then increase the amount of PGs over time for ongoing performance improvements, particularly if you find that there's a struggle that a particular benefit partner is having in achieving the desired performance. So anyway, so we were asked to kind of what typically do we see in terms of performance guarantees. Mercer's experience is about 20% is what we see for self-funded plans for the percentage of administrative services only fees at risk. We've seen a range of 5% to 40% of fees at risk. I was just on a medical RFP a couple weeks ago, and all three administrators offered 25% of fees at risk. They were all very competitive from a pricing perspective. So the administrators and carriers are becoming very common to offer up fees at risk. It's sort of expected these days, particularly from large self-funded plans. The other thing that we see typically with PGs is financial measures. So things like claims accuracy and processing, trend guarantees is one bucket, and the other is the administrative and operational measures, which we've mentioned, the block call rates, average speed of answer, claims turnaround time, and so forth. Clinical quality measures, I would say that you're really ahead of the game, both boards, since you've incorporated that into your performance guarantees. But for example, PEB doesn't have the administrative and operational measures in place, or the financial measures. I forget if OEB did. But so on one hand, you're really, I would say, ahead of the curve in terms of measuring and monitoring and putting fees at risk for clinical quality. But some of the meat and potato measures that typically I would see with self-funded plans are not present. And I would suggest that you consider incorporating them. Now, I saw that OEB has some, so I'm not, Margaret's the expert on the existing measures or performance guarantees, and I'm not. So if there's any questions about what's there, Margaret's going to be on the spot there to answer. But anyway, that's what we typically see. Go to the next slide. Forget what's next. Oh, categories. Yeah. So we came up with 6 categories. I will just tell you in the spirit of transparency that transparency was a new one. I've never seen transparency as a category, but some of my Mercer colleagues included it. It's an intriguing category. What I see is the other administrative, the financial, clinical quality, clinical management programs, account management are more common. So transparency would be an interesting one to consider. Go to the next slide. So this is really, it may be obvious, but I was asked to kind of give a real nuts and bolts of what PGs are about. So these are measures aimed at looking at claims administration, member services or call center. These are some examples: claims turnaround time, average speed of answer at the phone, block call rates, reporting timeliness and accuracy, and so forth. So this is really how are they functioning as a health plan, fulfilling the requirements of both around the claims processing as well as the member services or call center functionality. Next slide. Financial trend guarantees. So this could be unit cost performance guarantees year over year, utilization trends, cost transparency about percent of Medicare payment levels. Now that also is over in the transparency category as well. But this is really trying to cap not only the overall trend, but the unit cost increases that they negotiate with their providers in their fee schedule. Clinical quality PGs, you already know those, probably very familiar with them. Margaret went over them. These are, of course, based on the OHA's current Health Plan Quality Metrics Committee metrics. And so this is for overall population measures around preventive services as well as chronic care services. And there's a bunch of things underneath that. And then your CAP score, which is Consumer Assessment of Health Plan Satisfaction, I think was CAP stands for. And that's with the overall plan, not with a provider or a health system, by the way. So clinical management PG, so these are not the same as clinical quality. So in your contracts, your plan administrators do, for example, prior authorization or utilization management. They are engaging high-cost patients in case management, and so forth. And so these are the functions that the clinical management staff at the health plan are doing and measuring their effectiveness. So timeliness, engagement rates with high-cost claimants in case management, and then the impact, for example, of patient activation. So if someone enters a case management program, a couple of the carriers, I think, do this, administer the patient activation measure, and then further along during the engagement of the high-cost claimant, they remeasure. So you're looking at, did they improve the patient activation measure, their ability to self-manage their care, which is actually correlated with health service utilization. So it would be a stretch goal in addition to these timeliness measures, but I would say it would be a good consideration. So again, clinical management is how the health plan is managing the different clinical management programs, utilization management, case management, disease management, as opposed to clinical quality, which are overall measures around preventive screenings and chronic care guideline adherence. Next slide. Account management PGs are fairly self-evident, so that's, would be conducted with a survey of you and board members around your satisfaction level with account management. You could also take a look at timeliness of responses to requests from OHA staff as well as board members. There's usually just a couple related to this one. And transparency, again, is a really intriguing one that I think it was James Matheson actually suggested to put in. I, again, have not seen that. That still could be considered. I think it's a really intriguing one to have the health plan display their cost transparency around reimbursement for providers, like percent of Medicare reimbursement, the variability on payment, and cost per episode for the top 20 episodes. What you could do with this one potentially is, rather than putting fees at risk for this one, is actually ask the administrators to do a report only, so they just report out on it, and then you could take a look to see if you want to put fees at risk for this. Just an idea. And go to the next slide. I think then it's, yeah. So this is from the Health Plan Quality Metrics Committee. This is not a Michael Garrett thing. So just to be clear, these are the must-pass criteria when that committee, the Health Plan Quality Metrics Committee, selects measures of what they must pass in order to be included in the catalog of clinical quality measures for a given year. And then the next slide is the need to meet some of the principles. And so then there's a number of things listed there. So the previous one is must meet, and then this is need to meet some of the principles. So there's a bit of a difference. And the Health Plan Quality Metrics Committee does all this work in applying these criteria and principles when they go to select the clinical quality measures for that particular year. And I think, this is the set of criteria when they take a look at it. So they want to make sure that there is a mix of physical health, mental health, and so forth across all the different sectors. So, inpatient, outpatient, across data sources, so claims, data, electronic health record or clinical data, patient questionnaire, and then measures across the population as well as focus population. So I was really impressed to see this, that really trying to take a look at, are we measuring in a balanced kind of way, taking all those things into consideration. So that was great to see this. Yeah. So that's So I think the next steps, as Margaret articulated, is that if there is interest from this group, for us to flush out a couple things. One is more specific metrics in each of the categories, if you're interested in all 6 categories, and then also get examples of other performance guarantees by the categories, and then percentage of fees at risks. So we have medical RFPs from, I believe it's 3 other state employee benefit plans that we can highlight, as well as Mercer's book of business, and we could highlight for next month both the examples of measures by category as well as fees at risk overall and potentially by category, depending on the other state employee benefit plan data that we have.
Any questions?
Did I put everybody to sleep?
Wow.
So, yeah, so I think in terms of next steps, thank you, Michael. That was a lot of information, very, very concisely and efficiently delivered. And so I think, you know, what we're really looking for today from the work group is, first of all, sort of any feedback or reaction or thoughts you have about some of the content we've discussed. And I think in particular, you know, as I kind of laid out in the timeline, what we're proposing is that we come back in March and that we have, at that time, we would bring to you specific measures that we would recommend within each of the categories. And I think in the March meeting, then we would want to talk more about weighting, you know, what categories perhaps seem to weight more critical to the work group versus others. So before we, I mean, we plan to proceed with that work, provided that sounds in line with your agreement. But I think we'd also like to hear any feedback you have initially around measure categories, particular areas where things may or may not seem to be a bigger concern for performance. I think that, you know, to the degree that we can get some feedback and thoughts from this group, that will help us come back in March with a more robust initial proposal.
So I have a question. Michael, have you ever seen a progressive scale so that if the carrier has been meeting the mark for the last 5 years, or like 3, that maybe the amount at risk goes down with each successive period of time where they meet that target?
I've not, but I think that's actually a really interesting, you know, idea. It certainly gives an incentive, right, to them. No, I haven't seen it, but not to say that it isn't possible. I think that would be really actually incentivizing.
My concern is, if you get at what point does the number and the amount of performance guarantees actually give incentive to load up the administrative charge?
So I know you brought that up before. I don't see that, and particularly when you're doing a medical RFP, I just don't see that. But I mean, that's just my experience, is that doesn't happen. The other piece that you can do, again, I'm just thinking towards the medical RFP, is you can say, we want X percentage of fees at risk, say 20%. And you can, and then you have to evaluate the ASO fee compared to others. And you have a level playing field, like everyone's putting 20% of fees at risk. So then you can evaluate the price proposal accordingly. I would also suggest to you, if you have a relief after meeting the threshold, conversely, what you might want to do is, if they fail on, I don't know, 50% or more, then fees at risk go up.
Yeah.
I mean, what's good for the goose is good for the gander, right? Like, if you're going to give them a relief for achieving, when you might want to crank up fees at risk if they consistently fail to meet.
Well, under the flag of you're trying to address problems, I would totally agree with you.
And with PEB, since we don't have, for example, metrics on the administrative and operational, we don't know the answer to that.
Yeah.
And we've not, frankly, we've not done a claims audit in several years, so we don't know the extent of the problem.
You know, I do want to note on PEB contracts for administrative measures, we do get certain measures on a report only basis. So they are reported. They're just not an area where we've placed fees at risk, at least currently.
Yeah.
So.
And I like that, Margaret. I think that if there were problems that we would negotiate, or it would be negotiated into the contract, that there could then emerge, to Michael's point, penalties. So
another. Oh, go ahead, Sean.
Go finish your thought.
The other way to incentivize improvement, and Margaret alluded to it, is to increase the benchmark. So I've seen other contracts, particularly with value-based care, where you start off at, I don't know, 50% of national benchmark, then up it to 75%, then to 90%. And then the other approach with that, Jeff, is that you would then remove, particularly the clinical quality, you would remove that measure because they're meeting or exceeding it. And so are there other measures you want to consider? So that's another idea.
Yeah. Well, your report's been quite complete, I think, and gives a nice construct to apply, I guess, kind of in a matrix basis, an approach. So thank you.
Sure.
It looks like, Sean, you have a question on your face.
Yeah. So Michael, just being like a naive outsider, sometimes it's my prerogative to just like throw things in there like, what about this? And often it's just nonsense. But oftentimes I'm really thinking about what Jeff just said around problem solving. Like, what problem are you trying to solve? Mm-hmm. And for me, on some fundamental level, like trying to solve someone's problem presumes that I know what the problem is, and I don't.
Right.
What I know is my problem. And my problem is that I have to stay at 3.4% growth, no matter what. And that I need quality care, that, I'm getting, my people are getting healthier, not sicker. And, within, as a general trend, understanding we're all getting older, right? So, but in general, that they're receiving good care, and that the members are happy, like that they feel like they're getting good care. That's it, basically.
Well, I think there's another aspect, which is what's their experience with the plan, not just with healthcare providers,
mm-hmm.
but with the plan.
Sure.
That would be my yeah.
Yeah, fair enough. I mean, I think most people, they don't have like a clear concept about the division between this person versus that. They just know like this went well or it didn't, medical system details aside, And so I'm wondering from you if you've ever seen kind of like an attempt at a broad measures, like look, there's three, or, so if you don't, whatever the details were, if you come in over 3.4%, for example, that was the measure. Now, however you got there, fine. But while also maintaining quality, which we have quality measures. I mean, those are quality measures. And the members felt that they had a positive experience. And then it's sort of like the details follow from there. But that's ultimately just like, I'm expecting our costs to come in at this. And if they don't, you failed, like that was my measure. Is that a thing? Like have you ever heard of that?
So how I would translate that into a performance guarantee framework, what I'm hearing is that financial measures would probably be the most important, and put in trend guarantee absolutely in there, and you would probably load up that's how I would translate it. I would load up the financial trend area higher than the others. You could say if you don't meet it, because these are all financial penalties. It's loading up that trend is the most important one. Absolutely, and I've seen financial trend in there. I also just want to make a comment about what's the problem you're trying to solve. One of the problems you're solving is your fiduciary responsibility of oversight of the vendors, and this enhances that. So you're not just trying to solve a problem, but you're also trying to fulfill a fiduciary responsibility of managing these contractors. But that's an aside. But no, I've seen guarantee in there, Sean. Absolutely.
Well, that is useful to know. That's good to know. And to your last point, that kind of points to James's suggestion of the transparency component. I have to admit, I'm pretty intrigued by that. Yeah. Anyway, just
yeah. And the transparency, like I said, I'm intrigued by it. I just have never seen it, and so. One of the things that we'll have to decide, and Jeff, you've kind of alluded to it, is how many of these do we want? Like, we could come up with, we're going to show you a whole bunch, and what I think I will do is say, here's what I think is important. The trick's going to be the weighting. And I just feel, Sean, again, that your point that you just made is that the financial measures are probably the most important. So you would weight them very heavily. Yeah,
that makes sense. I guess my other question or point was just kind of having an eye on the measures that are of a high enough level that if you just choose a few of them, it causes the other ones to improve. Does that make sense? Like sometimes it's necessary sometimes for us at the PEB board to like really get into the plan's business, like show me your contracts, because we feel like there's something happening that we can't, we don't like the result financially, but we don't understand why it keeps happening, right? And so we're really getting into their business, and I'm always trying to think of a way to create an incentive that just like it forces them to solve their own problem, basically. Does that make sense? Like, it's like what are the few measures that are clever, eloquent, in the sense that they cause other things to go well, by achieving that. Yeah.
So let me kind of recap what I think I've heard is that there are two levels. One is all the areas that we want to measure and track. But all of those areas we measure and track don't necessarily have to have a performance guarantee associated with it.
Right.
The next thing is take that fees at risk and allocating them year to year, balancing that pending the performance. So in theory, you could put the whole thing at risk on one measure in 1 year, because that is a huge problem for us. Now, it never plays out that way, but I'm just trying to make the point is that we have a matrix that we can move around year to year, but we keep track of those same measures. So just because we had success for a couple of years doesn't mean it falls off.
Right.
Okay.
Yeah. The report only. Yeah. Yes. I think one of the things, I don't know that there's an elegant set of measures, to tell you the truth, Sean, that's going to solve it all. We see with plans that solve for the financial trend by not making a lot of denials. And or excluding coverage, or really clamping down on the clinical coverage policies.
Yeah.
So you got to have these balancing measures in place, because whatever you measure, there's people are going to try to do the workarounds. That's just, all of us do that. And so
Well,
that's why having that mix of measures. Go ahead.
I will wait with bated breath to see what you come up with.
Well, I can't guarantee elegant measures. That's all I can tell you, because things like block call rates and so forth aren't elegant, but they can be important if it's not happening. And I've worked with clients answered, getting inaccurate information from the customer service people or whatever.
I see that.
So that is where the rubber meets the road with memory and the claims turnaround time. If the claims aren't being processed timely, you're going to get people complaining, or they do hoop jumping to overcome denials. Now you may not be having that right now, but you just, if you clamp down really hard on one area, it's going to pop up potentially in others. And that's why this mix and having balancing measures may be appropriate. But don't want too many. Want to narrow it down. Absolutely want to have some report only measures. To I think both of your points, just to see. And if there's a problem in one of them, then oops, now it's no longer report only. It becomes fees at risk, because you're not performing well.
Right.
All right.
Cool.
Thumbs up.
Yep.
Thumbs up. My goodness, here we are at 3:36. We have lots of time for public comment. Should there be any?
Hey Jeff, can I just confirm, so the guiding principles and those kinds of things also resonated with people? Did that seem okay as well, or?
Did to me.
Sean or Kimberly?
JJ?
Yeah, it did.
Yeah. Okay, all right. Is that, out of rock out of discussion?
You're having some atmospheric interference.
Yep.
Okay.
Okay. Is there anyone who'd like to provide public comment? Is there anyone who'd like to provide public comment? All right. Hearing none. And I saw Rose try to come off mute, and I'm not sure if she's having some audio.
I was just going to study for public comment. Yeah.
Okay, thank you, Rose. All right. Well, I think that said, that brings us to our wrap up and next steps, which we've talked a little bit about already. So with regard to centers of excellence, staff and consultants will work internally to draft up information that the work group will then submit to both boards, asking for their either thumbs up or thumbs down approval in one way or another to pursue further work on a Center of Excellence program. And for the performance guarantees, I think we got some good comments and feedback. We'll be working behind the scenes to prepare a fuller proposal for what we would recommend for next year's contracts and bring that back in March.
Great. Well, thank you, everybody. Last chance for a comment. Meeting adjourned.
Thanks.
Thank you.
Thank you.